having state-of-the-art manufacturing capabilities, diverse therapeutic areas such as cardiology, diabetology, pain management, dermatology, ophthalmology, neurology, and more. Unlocking the power of science to provide access to affordable and innovative medicines to improve health outcomes and make a difference in people's lives across the globe. So the first product I'll be talking about is our Orilam ODT. This is our lamotrigine. We have it in both 25 milligrams and 100 milligrams. Our Orilam ODT, which is lamotrigine, can be used in bipolar disorder, partial onset seizures, primary generalized tonic-clonic seizures, generalized seizures of Lennox-Gastaut syndrome, and briefly into the mechanism of action. It enhances slow inactivation of voltage-gated sodium channels, contributing to seizure control in focal onset epilepsy. Like I said, we have flexible dosing options. That's to say we have it available in 25 milligrams and 100 milligram strengths, allowing individualized titration based on patient response. It's indicated as monotherapy or adjunctive therapy for focal onset seizures in adults and eligible pediatric patients, and also effective in generalized seizures of Lennox-Gastaut syndrome. It's more preferred antiepileptic drug among pregnant and lactating mothers, and our Orilam comes with ODT technology, and also at a preferable price of 14,300 Uganda shillings, a pack of 30 for 25 milligrams, and 17,200 Uganda shillings, a pack of 30 for 100 milligrams. And next, I'll be talking about our Opelan ODT. This is olanzapine or dispersible tablets, available in 5 milligrams and 10 milligrams. Our Opelan ODT is an atypical antipsychotic used in the treatment of schizophrenia and bipolar disorders in mental health. It has oral dispersible technology, and therefore it dissolves in the mouth without water, and it's useful for patients with swallowing difficulty and also improves onset of action. Briefly into the mode of action for our olanzapine, which is Opelan ODT. Our olanzapine works mainly by blocking certain receptors in the brain, and the key neurotransmitters involved include the dopamine, the D2 receptors, which reduces excessive dopamine activity, hence helping control hallucinations and delusions. Then the other key neurotransmitter involved is serotonin, the 5-HT2A receptors, and this improves mood, cognition, and negative symptoms. The indications where our Opelan ODT can be used include schizophrenia, bipolar disorder, and agitation in psychiatric conditions. The advantages of the ODT technology with our Opelan is there will be easy administration, no water is needed, and fast disintegration, therefore an improved onset of action. Then also useful in non-cooperative patients. Our Opelan also has flexible dosing options there, and it's available in both the 5 milligrams and 10 milligram strengths, hence allowing individualized titration based on patient responses. And a pack of 30 for the 5 milligrams is at 11,500, and a pack of 30 for the 10 milligrams is at 14,300. These products are readily available in all major pharmacies in Kampala and upcountry, and our kind request is for your support in form of branded prescriptions. Thank you so much, and I would like to now invite our moderator, Dr. Sedat, to take us through the next session.
Thank you, Sharita, for giving this introduction. Good evening, everyone. My name is Sadat Katama. I'm an associate consultant psychiatrist working with UMC Victoria Hospital, and today I am the moderator. I would like to welcome you once again to yet another session of this other session of the scientific initiative, where we are looking at different conditions and then the treatment options and how these treatment options have been found by evidence to perform in patients. And these sessions are supported by microlabs that brings you a number of products that are actually part of what we use in the management and care of our patients. And just as Sharita has been mentioning, those are some of the products that they actually do have on market. So today, we are going to discuss bipolar affective disorder, and particularly we are having a focus on the diagnosis and then the case of early intervention, because quite commonly we've seen that patients might delay to come in, or they first wander around other alternatives before they actually come to us. But then today, our expert is going to open our eyes to the need for early diagnosis and early intervention. So I am pleased to introduce today's speaker, who is none other than Dr. Harriet Biraba Okecho, a senior consultant psychiatrist working with Butabika National Referral Mental Hospital, and she's the clinical head at Butabika. She's a life coach. She says she struggles to manage her life, but she can help you manage yours better. So in case you're having any challenges, she's a very approachable lady. You can easily reach out to her and she will be very helpful. Today, our session is going to run for a couple of minutes, and then, of course, at the end, we shall have a part where we look at the Q&A, where the questions that you might be having from this session, or even any other parts, however related to this session, will be responded to. These questions you can ask. You can type the questions in the Q&A of the chat of Zoom. So if you go to the option of more, you're going to find Q&A, and under Q&A, you'll be allowed to type your questions there, and then we shall attend to these questions at the end. Without taking much of the time, allow me invite Dr. Biraba to take us away. Thank you very much. Dr. Biraba, you're welcome.
Please allow me to share my slides as well.
Can you please check, madam?
Yes, Dr. Biraba, I think you can share now.
Okay, thank you so much, Dr. Katama, for that introduction. I didn't think you were going to share that as well, but I think that's okay. In this very short time, I'm going to focus on bipolar disorders, diagnosis, and then the need for early intervention. I think I'm just going to focus on something brief about the historical development for bipolar classification, because I think sometimes it helps us to understand what bipolar disorder is. I'll not go into the details of the ICD and DSM-5 classification, but something on evolution and maybe the current classification and where it comes from. I
Dr.
don't
Biraba,
see whether yes, please.
just a moment. The screen is not showing. Maybe if you can share again. Thank you.
Is it showing now?
Not yet. I think. Okay.
Is it showing now?
It is now starting to share.
Is it showing?
Not yet. I think you can first stop sharing and then you reshare.
Is it showing now?
Still it shows that you are sharing the screen, but we can't see what you're sharing. Not yet.
Oh my goodness.
Madam, once you started screen sharing, can you go through the presentation so that the slide will be visible?
Is it sharing now?
It's sharing, but the slide is not visible. So that's what I'm saying. Can you click on the presentation?
Yeah, I'm on the presentation. Is it showing now?
Noted.
Not yet. I think you first, Doctor, first stop sharing. Then I
Is it
think
showing
you
now?
go to Zoom and share. Not really. Now you can start sharing.
Is it sharing now?
So it shows sharing, but we cannot see the screen that you're sharing or the presentation itself.
What do we? Because this here it shows it's sharing.
Maybe if you, yes, Ajit.
Yes, it's sharing, madam. So I'm saying, can you click on that presentation? So the presentation will be in your screen. Can you click on the presentation?
Yes, I have. Yeah, I have done that.
Then can you share me once again? Can you share the slides? Or can you?
Is it showing
Can you
now?
share?
It is showing now.
No.
Dr. Abhinav, I think you can share the slides with me, then I can present them. I can share them from my end.
It's going to take time. And it will be difficult for
Doctor, can you try like a once again?
it lose me completely at this rate.
Once again, can you try in the sharing?
Is this coming? Is it showing now?
No.
It could be an internet problem, Doctor. I think maybe if you can share with me your presentation, then I can present from my side. And then for you, just keep talking as I flip the slides.
I think I didn't take all the necessary measures that I needed to take.
I've shared my email with you, so you can share with me the presentation.
I think I have shared now on, I have shared with you, Dr. Katama. Have you got the presentation?
Yes, please. I've received it. I think, Mr. Dith, if you could allow me to share my screen.
I think I can start in the meantime.
Yeah, I think you can start then.
I'm sorry for that delay in that.
Yes, sir, you can share right now.
So we are discussing bipolar diagnosis.
Dr. Bidaba, please stop sharing, then I can share from my end because it shows you're still sharing. Right.
Okay,
Thank you. I hope my presentation is, I hope it can be seen.
Yes. Now it's visible.
All right. All right.
So could you please check on the presentation mode? Is it in the presentation? Yeah, it's okay.
Yeah, it is in presentation mode.
Yes.
All right.
All right, sir.
Dr. Bidaba, I think you can now continue. Thank you.
Oh my goodness.
Dr. Bidaba, you can also be scrolling from your side since we have the same side. So you can be doing it from your computer. For me, I'll be flipping the slides for the presentation.
Right. I think that's already disorganized, but that's okay. I've already talked about the outline of the presentation. And I think as we think about the diagnosis of bipolar, we are thinking about disorders where the main disturbance is that of the mood. And the mood can be seen as a spectrum with extreme states of melancholia or depression and mania. But the question always comes, are they opposite or are they separate states? Or are they different expressions along a broader mood spectrum? Some people argue that these mood disorders may exist along a continuum, but generally the current classification, like the Diagnostic Statistical Manual for Mental Disorders and ICD-10, creates clear boundaries for these disorders. However, we also realize that even when you have classified these disorders, you'll find that there are some that present with sub-threshold symptoms. Developmental factors can come into play, then the biological mechanism. And I thought that it's important for us to go through the historical development of bipolar disorder classification for us to be able to understand this. We actually find that mood disorders, when we think about the bipolar disorder specifically, even as early as the 4th century, Hippocrates described the mood states as melancholia and mania as distinct pathological mood states. And then Areteus also differentiated between mania and melancholia. But we also realize that in 1851 and 1854, around the same time, two people described mania and depression as alternating. Jean described it as different, as satural insanity. And then Jules Beilager described bipolar disorder by then as a form of double form insanity. So there were two different characteristics. Are they two different states? or are they occurring sequentially? Then when we talk about some disorders as we know them now, you'll see in the current classification that we have classification like cyclothymia. Then we think of Emily Kraepelin, who distinguished between manic depressive insanity and dementia precox, differentiating between schizophrenia and bipolar disorders. In the new classification, we have bipolar and unipolar depression, and that classification comes from Carl Leonhard. A gentleman called Akisco, I thought it was important to mention this, talks about bipolar disorders and classifies them into bipolar 1, bipolar 1.5, bipolar 2, bipolar 2.5, bipolar 3. The reason I'm putting this out is that you see that in the current classifications where we have DSM-5 and ICD-11, they take into consideration some of this. Because you may have a bipolar 1 where you have full manic episode occurring with depression, and as originally known as manic depressive insanity. Then there are people who have hypomania with major depression, what we now call bipolar 2. But he also put in that classification of cyclothymia. Then there are times when you have antidepressants causing a manic-like episode. And where would you put such a classification? Because of the time, I'm not going to go through the classification, the development of the classification according to ICD-10, according to the International Classification of Diseases and the Diagnostic Statistical Manual for Mood Disorders. Currently, what we are using, the DSM-5 and also the ICD-10 classification. The DSM-5 when we think of the ICD-11 and the DSM-5 classification, we realize that ICD-11 classifies bipolar disorders under the mood disorder framework. And then the DSM-5 has a category of bipolar and related disorders, and then depressive disorders. So you realize that the bipolar that we are discussing today under DSM-5, it is in bipolar and related disorders. And then under the ICD-11, it's under the framework of mood disorders. Both of them recognize that actually you can have bipolar 1 and bipolar 2. Then is recognized as an episode of bipolar disorder. And you can specify whether someone has psychotic symptoms or not. We'll look at the diagnostic criteria for a manic episode. But someone must have had symptoms for at least 1 week or less if the symptoms require hospitalization. And then the mood has to be elevated, expansive, or irritable. And in the DSM-5, we increase energy or activity is part of the diagnostic criteria. Hypomania, which is recognized as a category in DSM-5 and contributes to bipolar 2, you have consecutive days in which someone has observable change in behavior, but there is no marked impairment. Patient may not require hospitalization, and usually there is no psychosis. Now, we also know that in bipolar, you have an episode of depression. ICD-11 and DSM-5 classify them differently. But the most important thing to remember here is that there is a depressed mode, and then there is loss of interest in a pleasurable activity, which may be described as joylessness. ICD-11 also describes the mood as to whether, if someone is depressed, describes the mood as to whether, as the depression, whether it's mild, moderate, or severe. And then you can also specify whether someone has psychotic symptoms or not. DSM-5 just talks about a major depressive episode, and then a major depressive episode may be mild, moderate, or severe, and it can also have other specifiers, as we shall see. An episode can present with mixed states, mixed features. You can have depression with mixed features, but you can also have mania with mixed features. In ICD-11, it is taken as an episode, but DSM-5 takes it as a mixed episode. Depression and mania can present with psychotic features. You can have bipolar manic episode with or without psychotic features, and you can have depression with or without psychotic features. It's important to remember that, because that is when you'll be able to find someone failing to distinguish between schizophrenia and bipolar, because these disorders can also present with psychotic features. And what we mean by psychotic features are delusions, hallucinations, disorganized speech, disorganized behavior that can occur. In the classification, we also have what we call a cyclothymic disorder, classified both in ICD-11 and DSM-5. And here it includes mood disorders, hypothermia, and also hypomania, and also depression that may not meet the criteria for a major depressive episode. Then you also, in the ICD-11, you also separately discuss, you can have a manic episode that is being caused by substance abuse or medication. In DSM-5, that is regarded as substance or medication-induced bipolar. For example, if someone has maybe hyperthyroidism, if someone is using drugs or alcohol and they get a manic episode, according to DSM-5, that will be bipolar secondary, or due to a substance use, or due to a medication. If it's a medical condition, the second one, it could be due to a medical condition or due to substance abuse. So you'll find that in DSM-5, you can have bipolar either secondary to a substance abuse, or you'll have bipolar secondary to a medical condition. And that is still required, defined as bipolar. I'll go through why early diagnosis of bipolar is important. I know that I should have put in a little more slides to be able, for people to be able to understand the difference between, bipolar 1 and bipolar 2. A single manic episode, still someone will be referred to as having bipolar disorder, and that would be bipolar 1. If someone has a hypomanic episode, they will still be called bipolar 2 if they have both hypomanic and depressive episodes. Then cyclothermia, they will have hypomania with depression, but the depression will not reach the severity of a major depressive episode. We'll come back to that later. I think it was because of the time that I did not include some of the slides. But going to the early diagnosis of bipolar disorder, I think this is very important because very often patients with bipolar disorder present with depression, and they may not have a first manic episode. So when someone presents to you with depression, you may make a diagnosis of depressive disorder. But the question here will be, is this bipolar or this a major depressive disorder? Is this a single manic episode or is this a bipolar disorder? ICD-11 makes it a little bit clear because you can just make a diagnosis of a depressive episode. If someone has a recurrent depressive episode, then you'll call it recurrent depressive disorder. DSM-5 will make a diagnosis of major depressive episode for a first depressive disorder. But as I'm trying to explain, a single depressive episode may be a beginning of a bipolar episode. And it's very important to be able to make that diagnosis because it will influence the treatment choice, the prognosis, the safety, functioning, and also the prevention of future episodes. So it becomes very important, as we shall see in a slide later, to be able to distinguish between bipolar depression and unipolar depression. If you have a young person presenting with depression for the first time, you're thinking, is this bipolar depression or this is unipolar? If they've ever had a manic episode, straightforward, you say that's bipolar depression. But if they've never had, you still want to keep it at the back of your mind that this patient may be having bipolar, even if they are presenting with a depression for the first time. So here you have to think through and say, what is the age of onset? Bipolar depression, bipolar starts earlier in life compared to unipolar. You also want to say, is there a family history of depression, of bipolar in this patient? Because that alone may indicate that the patient you may be dealing with is having bipolar. You're also going to look at the symptoms this patient is having. Patients with bipolar tend to have atypical symptoms. Like, for example, in depression, you tend to have, instead of lack of sleep, they may sleep excessively. Instead of low appetite, as may occur in depression, you may find that they have increased appetite. So you need to be able to distinguish between bipolar depression and unipolar. Then, of course, if you are able to distinguish between the two, it will prevent you from giving inappropriate antidepressant monotherapy. Because antidepressants in patients who have bipolar depression, they may end up getting a manic episode. So that's why you need to know what diagnosis you're dealing with. It is also important to make an early diagnosis because you have to reduce the duration of untreated illness. When you have a patient who presents with bipolar, you're not managing only a single episode of illness. You are going to manage the illness longitudinally to prevent future episodes. That's why you need to be able to distinguish between bipolar and unipolar. It will also reduce the chances of suicide. The suicidal risk is there, both in depression and bipolar, but it's even much higher in bipolar. You realize that patients with bipolar may present with mixed features, meaning that someone can have both manic and depressive symptoms presenting at the same time. If you don't manage this well, you'll end up patients will have a higher suicidal risk. They will be cycling, moving from one episode to another, and then you'll not be able to manage them well. It's also important to recognize bipolar 2. A patient may present with depression, and the hypomania may have been missed. Because as I said before, the people at home may not be able to recognize the manic episode. They may just think, she was talking too much. She was more active than usual. She had many plans and ideas. But actually, when they have, they never received treatment for that. So they come in with depression and they have bipolar 2. And if you give them antidepressants, they end up getting a manic episode. You also want to be able to identify psychotic features, as we shall see. Schizophrenia, schizoaffective disorders can actually be differentials for bipolar disorder. The difference here may come in the relationship between the mood symptoms and the psychotic symptoms. For example, a patient with schizophrenia, they may have a secondary depression, but they will not have mood symptoms all the time. A patient with bipolar manic phase or depression may have psychotic features. Then patients who have schizoaffective may also have mood symptoms. They may also have psychotic symptoms. But the difference here is that they will have psychotic symptoms at the time when they don't have any mood symptoms. And you'll find that predominantly the symptoms they have are more of psychotic symptoms than mood symptoms. Then, as I said, there are bipolar spectrum presentations that you need to know. Having an early diagnosis is also important for patient education and self-management. There's quite a lot that you need to educate the patient on when you've made a diagnosis of bipolar. They will, of course, ask you what is the cause of the illness. They'll ask a number of questions. What are the implications of care? What options are there in terms of drug treatment? So it's important for patient education, for family and carers to be able to understand the illness, and of course to identify comorbidities. Bipolar can be comorbid with many disorders, including psychiatric disorders like anxiety, like substance abuse disorders, attention deficit and hyperactivity disorder, but also other medical conditions. So when you diagnose early, you're able to know that. Also, you're going to prevent other psychosocial consequences, like, for example, excessive spending. Many patients with bipolar can have risky investments, poor judgment, conflict with colleagues, absenteeism, impulsive relationship decisions, arguments, risk-taking. All that is going to be prevented when you make an early diagnosis. And you'll be able to treat. It will improve your treatment planning. For example, is this patient in a manic episode? Are they depressed? How am I going to prevent recurrence? What social interventions am I going to do? And then, of course, medication adherence becomes key. How am I going to prevent substance abuse and also suicidal risk? In the young people, if you diagnose bipolar, I think we have so many patients. If you don't diagnose it early, it's going to interfere with their education. It's going to interfere with their career development, relationships, social development, and family functioning. So all that is a very good reason for making an early diagnosis. So a useful approach to consider is if a patient presents with depression, ask, has there ever been a manic episode? Then you assess for manic features. And then you're going to say, how long has this patient had the symptoms? What episode am I dealing with? Is it a manic episode? Is it a mixed episode? Is it a depressive episode? Is there impairment in functioning? Are they do they have psychotic features? Is it substances or medications that has led to this? And are there medical causes for this illness? Then you'll be able to specify the diagnosis by saying, is this bipolar 1? Is this bipolar 2? Is this a cyclothymic disorder? Or is it other specified bipolar disorder? Or am I dealing with depression? I've already given us clues to suggest whether a patient has bipolar, a family history, early age of onset, decreased need for sleep, and then other symptoms. I won't go into that. After going through the early diagnosis, I think many people, I don't know whether it was very clear so far, but I wanted to emphasize that in bipolar 1, you at least have one manic episode, and a major depressive episode is not required to diagnose bipolar 1.
Excuse me, Dr. Vidava, if you
Yes,
could
please.
summarize in the next less than 5 minutes. Thank you.
Is it because my presentation is so good or the time is gone? All right. I think I'll allow for questions. I decided to put the diagnostic criteria for a manic episodes towards the end, because I know that this someone can look it up and say, what does a manic episode present with? And I think I'd mentioned that you have at least 1 week of symptoms, and you elevated mood or expansive mood with abnormally increased activity or energy. Some of the symptoms for a manic episode, I haven't gone through them, but there are many symptoms, but at least you have to have at least 3 symptoms, or 4 if the mood is only irritable. That next slide goes through the hypomanic episode. And then I have a slide trying to distinguish between bipolar 1 and bipolar 2. The next slide distinguishes between bipolar depression and unipolar depression. And then I have a slide that talks about bipolar disorder in children and adolescents. And there, the only thing I will emphasize is that the DSM-5 introduced the disruptive mood dysregulation disorder in order not to diagnose bipolar in all children. And this is distinguished by being that the children are chronically irritable, and they will have severe temper outbursts, and it's chronic rather than episodic. It doesn't mean that you can't diagnose bipolar disorder in children and adolescents, but it's very important for us to know that there are other disorders that may mimic bipolar. One of them is disruptive mood dysregulation disorder, but attention deficit and hyperactivity is another. Substance abuse is another that may mimic. So I think why early diagnosis matters is because you want to identify bipolarity. You don't want to misdiagnose bipolar as depression, and then be able to get appropriate treatment, reduce the duration of untreated illness, reduce recurrent mood episodes, improve psychosocial functioning to allow for suicidal risk assessment, and of course, improve patient and family understanding and prevent relapse. So in order not to take a lot of time, The take-home messages here is that bipolar disorder may initially present as depression. Do not assess only the current mood state, consider the past episodes before, obtain a life history of mood and behavioral disorder, and specifically ask for decreased need for sleep, energy, and activity, and assess for risk behavior. Always obtain a family history because it may help you to differentiate between bipolar. Then, because we know that antidepressants can precipitate a manic episode, always consider that as well. And sometimes you can have a mixed depressive and manic episodes. So it's very important to recognize bipolar disorder early in order to be able to reconstruct the patient's longitudinal pattern, and you don't focus on only the symptoms that they have currently. I think I'll stop there. Thank you so much, Dr. Katama.
Thank you very much, Dr. Virawa, for this insightful presentation. There is a way you always talk about bipolar, and most of us just keep bowing because you always bring out some things that we might not have come across or that really trigger our minds to go and research more. This has been very insightful. Our time is really fast spent, so I'm going to go straight to the questions. There are two questions in the Q&A, but I've also seen some in the chat. And so I'll read these questions and then you will respond to them, Dr. Virawa. So I think the first question has already been answered. There was a question about how we can identify bipolar disorder early in adolescents without confusing it with normal adolescent behavior. But I think in the presentation, there has been a part that actually talked about how to look out for bipolar in children and adolescents. Then there is a question here, Doctor. Is it possible for complete remission of bipolar disorders?
I think bipolar, as we know it now, is a recurrent illness. So our definition of remission really means has someone has not had symptoms for more than 2 months, then we'll be able to call that remission. I think maybe the question you want to ask, is there a recovery as far as bipolar is concerned? When we talk about recovery, bipolar is very heterogeneous. I've seen people who have had single episodes of mania, and the next episode comes many years, like when they are 50, and they never have another episode. There are people who have recurrent episodes almost every year. There are people who have rapid cycling. That means that they have even more than 4 episodes. So it is a very heterogeneous condition. But what we know is that recurrence is very, very common. But because it's heterogeneous, someone may have bipolar and they may seem to function very well. And some of them may be out of medicines for a long time. I think it's an illness that we really need to study, even in our setting. For people who are interested, there's a very interesting film called Brainstorm film that's being shown currently on bipolar. And it shows 5 people with bipolar, and it presents so differently. So that's why the question of recovery is a very difficult question to answer, because it presents very differently in very many different people. And I think that's why I didn't go through the historical classification, but that is what points towards differences in some people doing better than other people. But of course, when you add on things like substance abuse and other comorbidities, then the prognosis actually changes, and then it differs. And then, of course, there are other things that change the diagnosis, the prognosis, like age of onset, compliance to treatment, psychosocial function before. So there are other factors that may determine the illness.
All right. Thank you, Dr. Bidabwa. There's also another question here. I think this other question, for this one, we shall deal with it when we are looking at the treatment. Today we were focusing on early diagnosis. Someone was asking about the role of psychotherapy in the treatment of bipolar, but I think we shall discuss this when we are looking at management. So in the coming sessions, we shall be, one is happening next week. We shall be discussing next week, Monday, we shall be discussing some of these things. Then there was another question about how do you manage patients with bipolar disorder, with comorbid borderline personality disorder. I think the person who is going to deal with management is going to look at some of these elements. Just one question that I would like your response, Dr. Bidabwa. Someone says that, Nesigamo says that there are people we interact with who are always having fairly more energy with higher moods than others. Could they be having undiagnosed mania?
Thank you very much. I think that goes into my discussion, not being able to clearly define what a manic episode is. It's very important for us to know that there's a difference between normal moods, normal sadness, and normal happiness. I think this is where the diagnostic criteria comes in. So before you make a manic episode, you must have had these symptoms for a specific period of time. And then it disturbs your social and occupational functioning. That is very key in the diagnosis before you say that someone has a manic episode. So just having more energy with higher moods than others does not necessarily make you have a undiagnosed mania. But as I said, there's that diagnosis of hypomania, where there is changes in the functioning of an individual, observable by others. They just seem to be having more energy, higher moods, active, hyperactive. But for people who know the person, they may say this is not the normal person. And that could be a hypomanic episode. But then you don't go on diagnosing everyone as having a hypomanic episode. So that's where the diagnostic criteria comes in.
All right.
Maybe the other thing I wanted to mention related to that is that when we think about bipolar 2 even, we are not talking about mild bipolar. We are talking about an illness. And getting back to being able to make this diagnosis helps you when you're determining care. Like the sponsors for this event are talking about drugs like lamotrigine, olanzapine. And lamotrigine, for example, is very key in bipolar depression, especially. So you find that it may be a better drug. I'm not discussing management, but it may be a better drug for someone with bipolar 2 because it prevents the depressive episodes, which are more common in bipolar 2 as compared to bipolar 1. Olanzapine, for example, and fluoxetine combination may be used in treating bipolar depression, but then you're not going to give fluoxetine alone. You have to combine it with olanzapine. I just wanted to add on that to emphasize why we need to be able to classify these disorders, because they are going to help us to determine what treatment you're going to give.
Right. Thank you very much, Dr. Bidabwa. Our time is really fast spent. So for other questions that are still people do have, you can still send them. We can always respond to these questions individually, or you can even reach out to us directly. Just to remind you, Dr. Bidabwa has just talked about lamotrigine and then olanzapine, and Microlabs has these medications which are available to us, lamotrigine in Orilam and then olanzapine Opelan, brand names. And these are actually on our market. Maybe if Mr. Ajith Sharita can come in and just give a final word on this, and then we close. Thank you very much, Dr. Biraba, for this wonderful session you've given us. Yes, Mr. Ajith.
So thank you very much to the Uganda Psychiatrist Association for giving us the opportunity to speak with you during today's webinar. So we sincerely appreciate your active participation and valuable time. We look forward to bringing you a series of informative webinars in the coming months and hope you will continue to join us. And thank you once again for your support. And especially the thanks going to Dr. Harriet for such a wonderful presentation and Dr. Sadat for such a wonderful moderation. And also, finally, requesting for the branded prescription, which Dr. Sadat already mentioned. We do have a lamotrigine, which is called Orelam ODT with affordable price. And we do have olanzapine. The brand name is Opulent 10 and 5 milligram. So requesting for your branded prescription for all these brands. Thank you so much.
All right. Thank you, Ms. Adi. Thank you, everyone, for attending. We shall have another session next week on Monday, same time at 7 p.m. We keep time, and then we shall be cruising well. Thank you, everyone. Have a lovely week.
Thank you, doctors.
Thank you.
Your permission, can I close the webinar?
Yes, please. I think you can close it.
Okay, please. Thank you so much.
Recording stopped.